Good afternoon. I'd like to welcome you to today's Medical Center Hour, which is combined with Medicine Grand Rounds. This joint program is the medical school's annual Brody Medical Education Award Lecture, which will be presented by Dr. Gerard Clancy, the 2017 recipient of the Brody Medical Education Award. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we produce the Medical Center Hour. We often partner with departments like medicine on programs like this where there's great interest on all our parts in the topic and in the guest. Dr. Clancy is president of the University of Tulsa in Tulsa, Oklahoma. He is a psychiatrist and a longtime advocate of transformational work in urban community health and in medical education, a remarkable physician leader, change agent. His talk, A Story of Success in Reversing Urban Health Disparities, is premised on recently recognized and potentially transformative social and medical facts. Where you live in a particular U.S. city may well determine your predicted life expectancy. Neighborhood can be destiny, in a way. For example, in New Orleans, a fully 25-year difference in life expectancy divides one parish from another barely 3 miles away. Not surprisingly, as Dr. Clancy will point out, this pattern of great gaps in health status, even over short distances, just across town or over the railroad tracks, repeats itself in other American cities, New York, Chicago, the Bay Area, St. Louis, all with harsh consequences. In 2005, Tulsa, Oklahoma was one of the first U.S. cities to acknowledge dramatic neighborhood variations in life expectancy and to take action. In 10 years, the community brought about a reversal of major health disparities and improved the health of the people living in North Tulsa. This is the remarkable story that Dr. Clancy brings us, a story of vision and commitment, inventive planning and interprofessional partnerships, risks and trust, and sustained hard work, leading to constructive change. Tulsa's success is a vivid and worthy example, but it's also a challenge. What lessons may other localities, including our own, discover in Tulsa's experience? And what are the respective roles of academic medical centers like UVA and individual clinicians for finding the will and the ways to reduce health disparities in our midst? And what about medical schools and residency training programs? What are our responsibilities? How do we best orient and structure curriculum, clinical training, and community engagement to most appropriately prepare the next generation of physicians? Medical Center Hour and Medicine Grand Rounds are proud to present the Brody Lecture in partnership with the Brody Medical Education Award Committee, the Medical Schools Academy of Distinguished Educators, and the Department of Medicine. And lastly, I'll mention that Dr. Clancy has no personal or professional relationships with commercial concerns that produce healthcare goods and services. So, Dr. Gerard Clancy, welcome and enlighten us.
Well, thank you, Marcia, and it's a joy to be here. It's great to come to a medical center like this that has the very traditional grand rounds, and I've enjoyed being here very much. Evan has been a wonderful host and has taken me all around town. You know, I've heard across this medical center that there is many goals, but one of the goals is for this to be the healthiest place to work and live. And that sounds like a pretty high bar, pretty complicated task to be the healthiest place to work and live. And the message that I'm going to bring to you today is, first and foremost, this is good, noble, worthwhile work. And second of all, you can make progress on things like this. It actually is doable, even though it's incredibly messy. And so today is not a scientific lecture at all. I'll show you lots of data, but it's really more about the messiness of this work and the need for you to be comfortable with being messy. And I'm a fairly obsessive person, and so for a while that actually bothered me a great deal as far as the messiness of this. But we're going to, there's two parts to this talk. The first part is Tulsa as our laboratory as far as making some improvements in some pretty significant health disparities. And then the second part of this talk is how that success actually has put us in position and inspired us to do another round of it. So one phase of success has pushed us forward to do another phase of success. And so Tulsa is our laboratory, and so we're going to go over Tulsa. So I come from Oklahoma, a state of 3.8 million people. We have the highest percentage of Native Americans in the United States. And we have a culture in Oklahoma that is very deeply rooted in fierce independence. You're supposed to take care of yourself in Oklahoma. and that roots back to several major historical milestones within Oklahoma. First of all, we were the end of the trail for the Trail of Tears during the Indian Removal Act, when the Native Americans were removed from the southeast United States and moved to Oklahoma. That set up a great mistrust of the U.S. government by the Native Americans. We're also the source of the land run in 1889, and many of those land runners were post-Civil War Southerners who did not have great trust in the federal government. The third is that we are the site of one of the nation's worst race riots. In 1921, we had a very affluent African-American community doing great. It was called Black Wall Street, and we had a terrible race riot where 35 blocks of Tulsa were burned down and over 300 were killed, and it barely hit the news. It was actually squashed by the Ku Klux Klan as a national story. And then last, we're a state where the Dust Bowl has had a huge impact on our psyche and surviving the Dust Bowl. Many of our Oklahomans left in the Grapes of Wrath to California, but many stayed behind. And those that stayed behind feel very, very mistrustful of the federal government as well, because they feel like they were talked into coming to Oklahoma and made promises that did not come true. We're also a state very strong in oil and natural gas. Tulsa, Oklahoma, my home, is a city of about 1 million people. It is a city with great wealth and great poverty. We are very, very spread in that aspect. And we have a history of racial divides, white versus black, dating back to our race riot of 1921. It's a beautiful state. We're in the northeast corner, and we're a city that is very active and very dynamic. And it's a city that I love very much. It's got real problems, but it's a city that, for me, has become a laboratory of relationships where we've been able to get some good works done. It's a state where the weather really has a huge influence on us as well. This is my phone, and this is the app that I have for tornadoes called RadarScope. Virtually every Oklahoman has the RadarScope app. And that app comes from the National Weather Center in Norman, Oklahoma, and it is the same one that the National Storm Center uses to spot tornadoes. And I can tell you all about the structure of this tornado. This is the tornado that hit Moore, Oklahoma just several years ago. And right here, you have the inflow boundary, and right here you have the left rear flank. And this is the hook echo, and this is the debris ball of the tornado. So when I see one of these, I know not to drive in that direction in Oklahoma. But weather has very much influenced us. We're also a state that the Dust Bowl, as I mentioned before, very much influenced us and really has people pulling back and saying, you really need to take care of yourself first. And it influences many, many things as far as policy in our state. We are a state that does not have Medicaid expansion, and it does not look hopeful for quite some time as far as Medicaid expansion in our state. But we also have some great works. We have the Gilcrease Museum at the University of Tulsa that Thomas Gilcrease in the early 1920s and 30s started buying as much great American art that tells the story of America. And they have over 1,300 Thomas Moran paintings. These are row after row after row, stack after stack of Thomas Moran paintings. It's absolutely gorgeous to go there. And if you are ever there, it's one of the things I want you to go see. In that wonderful art museum are also huge pieces of art that tell the story of the Great American West. This is Shoshone Falls in Wyoming. Absolutely beautiful, absolutely beautiful. Alongside the art, we have archives. And when I knew I was coming to Virginia, I said I needed to look up Thomas Jefferson. And lo and behold, we have a letter from Thomas Jefferson in our archives that I was actually able to handle last week. It was really quite something special. And the letter, there was a great part of the paragraph. It was dated July 1st, 1776. He's writing a letter back to William Fleming in Virginia. And William Fleming has said, why are you staying in Philadelphia all summer long? When are you coming back to Virginia? And what he has said is, if any doubt has risen to me, my country will have my political creed in the form of a declaration which I was lately directed to draw. He was hinting at the Declaration of Independence is coming. And it was really just fabulous to be able to tie this visit to Thomas Jefferson, and there's me poring over the letter very carefully. And I was told, don't touch it. And it says, the archivist was very nervous about where my hand was. Right there. But I behaved. I was a good boy. We also now have the Dylan archives. Bob Dylan's archives are at this. So this is an evolving American museum, but it's very interesting. So let's get into our work in Tulsa. I think that's what's next. Oh, no, we have a copy of the Declaration of Independence as well. There's roughly 4 different drafts of the Declaration of Independence out there. We have one of them. And what's been very interesting about our museum is they're able to do fingerprint analysis, and they've been able to see that both Benjamin Franklin and then Silas Deane were the handlers of this draft of the Declaration of Independence. And Silas Deane was an interesting character. He actually turned against the Revolution later on. He was pro Britain during that time. So let's talk a little bit about America and its current health right now. If you look at reports from Commonwealth, RWJF, CDC, and United Health Foundation, you see a very consistent set of maps when you ask a question about a particular issue. Up here, this is high school graduation rates in the United States. Purple is good, tan is bad. And you see this divide right along here. This is health system performance from the Commonwealth Fund. And you see that dark blue is bad and lighter blue is better. This is from United. This is overall health. Again, dark blue is bad. Our colors at the University of Tulsa are blue and gold, and when I first started showing these maps, the guy that does all the graphics changed all the bad colors to red instead. It was quite interesting. But these are the actual maps that we got. Here in the center one, the center square, we have physical inactivity. And if you don't have much physical inactivity, you are set up to have diabetes. And if you have diabetes, you're set up for cardiovascular events. And you see Tulsa, Oklahoma being right there. And if you have cardiovascular events, unfortunately, you have cardiovascular death. And that relates to overall mortality in the United States as well. And the dark blue here is bad. So you see this continental divide in the United States. And this is one of the papers, or one of the charts, that when I'm teaching my health disparities class with the medical students, I ask them, explain this to me. Write me a paper on why is our country this way. And the whole class is around some of those issues related to this. Well, not to hammer home an additional point here is that Oklahoma wasn't always out of touch with the rest of the country as far as health. Back in 1968, Oklahoma's health, and this is age-adjusted death rates, was very similar to Colorado. But something happened in the 90s or so where we started splitting off from the rest of the country, including Colorado. And this is another chart that we show the medical students and ask them, explain this to us. What probably happened in here is that we had an oil bust. And when we had an oil bust, those that could leave Oklahoma that had means left Oklahoma. And it was like a second Grapes of Wrath, that those who were left behind really were high in poverty and did not have jobs that they could travel. Well, not everybody in Oklahoma is unhealthy, but if you rank cities by health, this is from the Commonwealth in 2012, and they've repeated this in 2016. These are the 306, these are, of the 306 cities that they rank, here's the top 30, here's the bottom 30. Iowa City, where I'm from, is number 20 or 21 there. But Tulsa, Oklahoma, where I'm from now, is 281 out of 386. Lawton, Oklahoma is 286 out of 306, and Oklahoma City is 298 of 306. So that points us in a direction of where in Tulsa do we need to do some work. And back in 2005, I asked our College of Public Health to work with our health department to start teasing this out. And this is the first map that they showed us in 2005. And the first thing that they noticed in Tulsa County was that we had a maldistribution of physicians. 40% of the population in Tulsa County lives up here, but they had access to only 4% of the physicians easily. And our number one reason for patients not showing in our clinics in South Tulsa was transportation issues. Where there are the least likely to be the doctors is where the age-adjusted death rates were the worst. And again, this is Interstate 244 that divides the town, 40% of the population living up here. This zip code, 74106, being the worst zip code in Tulsa County. And that equated to a 14-year difference in life expectancy between North Tulsa and Midtown, where I live, right there. And the University of Tulsa is right there as well. Very short distance. And after we did that study, a few years later, we got visited by the Robert Wood Johnson Foundation, who asked how we did this. And we said we had to do a lot of it by hand. Back then in 2005, most of the health reporting was done by way of county and not by neighborhood, not by zip code. And so we had to go into the database and start calculating from the database by hand. And in 2010 is when RWJ visited us. In 2013, they started releasing additional cities that they've studied. And as Marcia described, New Orleans had a 25-year difference in life expectancy across a very short distance of only 2.5 miles. And they saw similar results in Kansas City, in Washington, D.C., in the Twin Cities, Bay Area, Richmond, Virginia, and St. Louis. I believe Richmond is now about 20-year difference between one part of town and another part of town. And in St. Louis, between Ferguson and the west suburbs, it's almost 30-year difference in life expectancy between one part of town and another part of town. So that started us down a pathway of, can we make a difference on this? And in 2005, we came together as an entire community, business, hospitals, medical schools, federally qualified health centers, philanthropy, and we put together a plan from that data called the Lewin Report. And our goal was try to make a difference on health, but we had no idea that we actually could make a difference on life expectancy in such a short amount of time. We just wanted to slow it down a little bit as far as these disparities. So some of the things, when you looked at the map back then, in North Tulsa, average life expectancy was 67 years old. Down here, in more of the southern part of town, it was 81 years old. We noted that North Tulsa had 3 times the national rate of cardiovascular and cancer deaths. North Tulsa had 40% of the region's population, but only 4% of the region's health programs. And when I was teaching an undergraduate honors class at the University of Oklahoma, discussing this map, I had one of my students start tearing up. And I, as a good psychiatrist, asked, are you upset about something? And she said, yes, I'm from North Tulsa. And I've always known this difference existed, but no one has ever talked about it. So another student on the other end of the table who was fidgeting and kind of shaking a little bit, and I asked her, did she have anything to say? And she said, I'm from South Tulsa, and I'm embarrassed. I never knew we had such life expectancy differences like this. In fact, I've never been to North Tulsa as well. And that was one of the most important lessons that I learned along this journey, is that to actually make improvements on things that are not pleasant and can be embarrassing for a city, you need to be honest about the data. When we started releasing this data, the Chamber of Commerce was not particularly pleased about the work that we were doing as well. That shined a negative light on our city as far as economic development. But to get something done, we actually had to take that data and make progress on it and let people know. And it really served as a rallying number for us. That 14-year difference in life expectancy got people upset and got people motivated to take action. Now, I was feeling pretty good about this because we were raising money to make a difference on this. I'd raised $20 million to put a new clinic right up here in North Tulsa. I was being asked to speak all over the country on this. And the North Tulsa leaders asked me to be the Grand Marshal at the Martin Luther King Parade in January of 2010. And so I thought I was pretty darn cool. I'm rocking it. Right before the Martin Luther King Parade and right before the groundbreaking of this clinic, this is the headline that came out in the North Tulsa newspaper. Is Tulsa North being pimped by OU? And my boss, who was the president of the University of Oklahoma, called me up and said, "What did you do?" And we were mad, and we were embarrassed, and we were offended by a headline like this because we were going to do such great things. Well, the writer of the article, James Goodwin, who has become a very good friend of mine, wanted to make the point that in the article, pimps use bodies for financial gain. The University of Oklahoma was coming into North Tulsa, going to offer clinics and financially benefit from North Tulsans without any other benefit to North Tulsa. And Jim's family, I learned later on, was one of the families that lost the most amount of property during the race riots of 1921 and has always had a very, very strong drive for economic development in North Tulsa. And he saw this as an opportunity, and we were not paying attention to this opportunity. We met with Jim Goodwin, the university officials. We asked Jim, what are you getting at? And he said, the university has so many wonderful resources from all your different colleges, all your different departments. Do more than just bring health care. Bring economic development to North Tulsa. As far as building the building, please hire North Tulsans to help build the building. As far as staffing the building, please hire North Tulsans to help staff the building. As far as recruiting medical students into your medical school, recruit them from North Tulsa so that they will come back and practice in North Tulsa. That moved our president so much that he said yes to all those things. We totally changed how we contracted for our building, totally changed how we hired for staffing our clinic. And in the past, minority participation in any construction project, the highest it had ever been in Tulsa County was 4%. And for this clinic, we were able to get to 25% of the clinic built by North Tulsa contractors. And the first 8 individuals to be on the work site actually walked to work from North Tulsa. So, and it really turned the tide as far as our relationship with the community, and it turned our tide as far as the university thinking bigger and beyond just healthcare. And it's a lesson I will never forget going forward. And it taught me that I remember the speech that our president was going to give as far as the groundbreaking for our clinic. It was laced with comments such as, we're going to do this for you. We're going to do this for you. And I looked at the speech and I said, President, we have to say with, not for. And he changed the speech, and it made things much, much better going forward as far as our intentions. But in anything that I've done since then, I've always remembered you must look at history going forward when you're working with the community. And these are pictures from 1921, the Tulsa Race Riot, where, again, 35 blocks of downtown Tulsa, Oklahoma were burned down. The grandkids of the race riot survivors are very active in our community, and this is very sensitive and very raw to them still. And I totally missed it. I was driven 100% by data. I was driven 100%, we are doing the right thing, and I totally missed the opportunity to work with the community going forward. But fortunately, the community told me, you have to back up a little bit, now work with us, and it's worked well since then. And in 2015, we redid the study on the life expectancy difference, and we had invested $40 million in new clinics. 4 new clinics were added, multiple new clinical programs, 37 new doctors added to North Tulsa, 1 program specifically, the heart intervention program, free cholesterol, or free statins, free lisinopril, and free aspirin to individuals at extreme high risk for heart disease and stroke, and it given to them for free, funded by our foundations in town. 300 individuals in the program now for 6 years. And really good outcomes on that. Cardiovascular disease and diabetes and infant mortality all improved at a time when our poverty rates actually worsened in North Tulsa. We didn't expand Medicaid, and poverty got worse, and so it was beyond economics. The thing that we're most happy about is that average in North Tulsa of 67 years of life improved to 70 years. So a 3-year improvement in life expectancy was realized in just over a decade. And so my message to you as an institution, you can make progress on what seems to be impossible problems. It seems like that's just way too complicated to address. But in this instance, it actually worked quite well for us. Quite well, and it surprised us. It surprised us to the point that when the health department did the study, I said, you need to call up RWJ and VCU and see if they will redo it to make sure it's right. And they came through and they redid it and said, yeah, you're right. You did make a difference like that. So we were quite pleased by that. Quite pleased. So, in thinking about the future, about healthcare and what's going to happen next, this type of work is actually becoming more and more important to a health system. Right now in America, in healthcare, revenue over time, you make your most amount of money by doing volume of services. You make money with procedures, specialty care, in the hospital, how you negotiate with the insurance companies, pharmaceuticals, and medical devices. And that's the blue line. In general, the trend is down in those areas at the expense of this area and this area. So if that's the volume service line, we're seeing much more money going into the quality service line. And Dr. Shannon is a champion of this across the country. That hospitals and health systems are rewarded for quality outcomes and penalized for bad outcomes. That's rocking and rolling right now, and that's the red line. We're seeing more money move into this type of revenue potential and less from here, driven by payers and corporations and employers wanting to pay for value rather than just pay for volume of care. On the horizon, though, is this idea of actually population health, where a large amount of money is given to an institution to take care of a large population for a long time. And that changes everything as far as incentives. It is the opposite of over here. The goal now is to keep people out of the hospital, to keep them out of the emergency room. And this is where what's happening in the city and neighborhood variation now really counts. What happens with race and culture and poverty, with health literacy, addiction, and mental illness, all now count. Because if you don't pay attention to these things, people actually end up in the hospital, and you will lose money because your payment system is different. That's the green line here. Now, will all this come true? I have no idea. We are in a period of flux again with health reform. No one really knows what's going to happen next. But at least I know that when I'm working with our companies, when I'm working with our major corporations who are now self-insured, they want to go in this direction. They want to pay for population-related health. They do not want to pay for volume care. So some of this will survive no matter what going forward, because this is what the employers want going forward. So our success with the north-south health disparity led to a major foundation in town coming to us and saying, do it again. We want you to do 10 more years of planning for Tulsa, but this time we want to look at early death driven by mental illness and substance abuse. And so I'm just going to give you a taste of what we're learning about our community. We don't have our plan in place at all, but we've got some pretty disturbing statistics. This, again, is a community-wide effort. It has philanthropy and business and universities and nonprofits and the state all working together. And we have a coordination council from the University of Tulsa leading the effort. Some of the things we're learning: stigma persists about mental illness. There's still many, many people who believe that mental illness is a character weakness, and if only you tried harder, you wouldn't have a mental illness. We also have realized that there really is no system of care for the mentally ill. It is total chaos. This is our Laureate Institute of Brain Research, about 60 very, very dedicated researchers who have come from across the world, funded by a Tulsa philanthropic organization, and they're studying the neuroscience of mental illness, and it's extraordinary what they can learn from their fMRIs. This is just one example. This is a Tulsa football player This is his MRI at rest. Right here is his functional MRI at rest. The red essentially is measuring brain connectivity. After that player has had a concussion, you see that the connectivity has gone away. A week out, connectivity is still not back to normal, and it takes a full month for that brain to actually come back to normal as far as connectivity. But normally we would have put that player back in class, we would have put that player back in his car, and we may have put that player back out on the field as well. So this is the type of work that Laureate Institute of Brain Research is starting to see as far as mental illness as well, and the roots of this. And it's extraordinary work. And we just have to push that the mental illnesses are brain illnesses. While we were ramping up our work, the National Academy of Sciences came out with this data, which was very eye-opening. If you look at mortality across the world, mortality since 1990 has improved in almost every area across the world except in one group. In the U.S., white males aged 45 to 54. And they are dying more often now from drug and alcohol overdoses, suicide, and chronic liver disease. So it's just a sign that this is a problem all across the country, that mental illness and substance abuse are having a major impact on disability and on mortality in our country. In Oklahoma, we rank 50th in the nation, worst, in adults who suffer from some form of mental illness, 45th overall as far as getting access, 47th in adults with thoughts of suicide, and we're 46th in the country on spending mental illness, so it's not good. The mentally ill in Oklahoma use alcohol and illicit drugs to self-medicate when they can't get mental health care. My clinic work is in North Tulsa in the clinic that we built, and if a patient misses an appointment with me and they don't refill their prescription, it is very normal for them to turn to methamphetamine as a surrogate for the medications that I was prescribing them for depression. And in North Tulsa, using methamphetamine is normal, and in North Tulsa, going to jail for drug abuse is normal as well. There is very little shame with that. Our subsidized housing is surrounded by a drug culture. We have inadequate food support. We have shameful coverage as far as Medicaid expansion. And the newest number that came out for us that is quite a surprise is that the mentally ill across the nation don't get care for their medical conditions. They don't get their blood pressure taken care of. They don't get their diabetes taken care of. And on average in the United States, it's about a 20-year shorter life expectancy apart from suicide. But in Tulsa, it's a 29-year shorter life expectancy. So that's going to be our number that rallies us. Just like the 14-year difference in life expectancy rallied us over the past decade, this is going to rally us going forward. We, like everybody else, are seeing a huge rise in prescription drug deaths. The red is the more intense, the more frequent prescription drug deaths. This is 1990. This is now 2009. You just see this epidemic across the entire country. We are a city that actually is very much influenced by the Mexican drug cartels as well. Interstate 35 branches off at Oklahoma City, and then Interstate 44 goes to St. Louis, and then up to Chicago. Those things have influenced us greatly as far as being a distribution point for all sorts of drugs and activity that come up from Mexico. It is not uncommon to have a $10 million cash drug bust on the interstates of Tulsa, Oklahoma, where somebody is transporting that amount of dollars back and forth between Mexico and the U.S. Pretty extraordinary. When we did our first mapping since our newest form of mapping, we looked at where is the cardiac and cancer death still 3 to 4 times higher than the national average, and it's still in North Tulsa. We still have that 11-year difference in life expectancy. We have another section of high cardiovascular and cancer deaths down here, and that's Section 8 subsidized housing. But we were very surprised to see that suicide is in different parts of downtown, or different parts of town. This is East Tulsa, mostly Hispanic. This is downtown, and then this is another Section 8 housing area, mostly Hispanic. And then prescription drug overdoses were here in the middle of town. And this is affluent, private school, very well-to-do Tulsa. So here's examples of lack of access to care, and here's an example of over-access to care, but still both of them leading to death, unfortunately. This surprised us very much. I thought everything, I thought all the issues would be related directly to North Tulsa, and they're not. It's spread out across town. And so we'll have programs in these neighborhoods specifically around that, and we'll have programs specifically in that part of town as far as overdose as well. When we looked at our beds, and Dr. Shannon and I talked about this a little bit yesterday, or the night before, we actually don't have a problem with not enough psychiatric beds in theory. The ideal is about 50 beds, psychiatric beds per 100,000 in the United States. Tulsa is at 47. We have 463 beds in town. That should work for us, but the problem is these beds are full all the time. As soon as a bed opens up, another one, and somebody else has to come in. And I used to be the gatekeeper for the psychiatric beds. 100 beds, and at one point a waiting list of 100 to get into those beds. It was a terrible job to be the gatekeeper for something like that. You had to pick who on this list of 100 deserves a bed the most today. It really was bad. We're way short on psychiatrists as well. United States, 1 psychiatrist for every 6,000 people. Oklahoma, it's 1 psychiatrist for 14,000. Terrible number. I need to recruit 321 psychiatrists to Oklahoma to get us to the national average. So I'm just making the point that we have such a dysfunctional system, we need to think entirely differently about mental health care. Because I'm not going to be able to recruit enough psychiatrists to do the work. It needs to be thought of differently, and the role of a psychiatrist needs to change. Our inpatient beds are full all the time because the outpatient system is not able to prevent and limit psychiatric emergencies. We don't have enough psychiatrists. What we're seeing is primary care, inpatient medical, general medical wards. The Tulsa Police Department and Tulsa County Jail instead receive everything that we can't handle in the mental health system. There's no coordination of care. It is a circus out there. And then major influences as far as substance abuse, drug trafficking, and violent crime. So the last project we did, 2005 to 2015, was complicated, but we knew where we needed access to care, in what part of town, and we knew exactly what services. This is much more complicated set of problems to try to fix going forward. Much more complicated. We're going to need PACT programs. If you haven't heard of PACT program, it's like a hospital team without walls and sees individuals with chronic mental illness every day out in the community. As a young assistant professor, I was a PACT team psychiatrist. It was great, great work. Some of you, I've told this story, but it was a typical college town like Charlottesville, where there's nowhere to park. So we would ride our bikes with the med students. Med students loved it. They just loved coming to school and saying, we get to ride our bikes today. I would wear shorts on hot days. I would have a backpack full of medications. Newspaper dubbed us Sykes on Bikes, which was great. But the police department didn't read the article, and I was in the pedestrian mall, just like you have downtown, and I found an individual who I'd been looking for, who was homeless, mentally ill, and was my patient. Run out of his medications. I handed him his medications. Police officer saw a guy with a backpack wearing shorts and a bike and said, that's a drug deal. And I made a trip to the police department. I didn't call my wife. I called my department chair and I said, get me out of this. And Chief R.J. Winkelhockey really had a hard time believing that I was actually a psychiatrist. Another thing we're going to do is create a behavioral health guidance center, something that is staffed 24 hours a day, 7 days a week, like 911. We have 211 in Tulsa, staffed with social work, psychiatric nurses, and psychiatrists to be able to guide people to the right places. Right now, there is nothing like this in our state. But we're going to guide people to the right place at the right time rather than the chaos that we have. And then the last thing we're going to try to do is shift to a mindset of prevention. Well, my dad was a University of Iowa professor of psychiatry. He taught me. And when I was in medical school in 1988 and then finished residency training in 92, I frequently heard from my faculty, you can't prevent mental illness. And that was kind of ingrained in me. Your job is to treat mental illness. You can't prevent it. But there's some new things that are happening out there. The first is the Israelis are becoming very skilled, unfortunately, at prevention of post-traumatic stress. It's a country that is under the threat of war at a regular schedule and frequently has terrorist attacks. They have an early response team every time a trauma happens. And I was in Jerusalem in in early January, and a terrorist attack occurred, unfortunately. But I watched the team in action where, after those that were injured physically, a second wave of ambulances came and took everyone that witnessed the event to a psychiatric emergency room. And lo and behold, intervening early like that actually prevents post-traumatic stress. They learned it from the military, and they transitioned it to society. We also can do some secondary prevention with some of our mental illnesses. If we did PAC teams at the first onset of schizophrenia, we actually would change the course of schizophrenia. Traditionally, schizophrenia is an illness that just gets worse and worse as far as functionality as the decades go on. But if you apply this early intervention, aggressive, very fine-tuned medication and rehabilitative approach that the PAC teams do, you actually change the trajectory of schizophrenia and you maintain function. Same thing if you treat a first depression the first time in an 18-year-old. You prevent further episodes later on in life. There's a kindling effect of one depression begets another depression, begets additional depressions. If you treat the first depression incredibly well, you can prevent other depressions later on in life, but we don't think like that right now. And then lastly, along this journey, we've had our medical students all the way, and it's been a joy. We changed our name from University of Oklahoma College of Medicine to the OU, University of Tulsa, School of Community Medicine, with a mission to improve the health of entire communities. And the action word is entire. And we start the academic year with a summer institute, where we bring together all the new med students and physician assistant students, and new nursing students, and new social work grad students, and urban design, and human relations. And the different colors are the different disciplines there are people in it. It represents the hood on their graduation gown. And we as a group for a week learn the anatomy of the community before we learn the anatomy of the body. And it's very influential on all the students that medicine of the future is interdisciplinary, interprofessional, and working together is very, very much necessary. We have required courses on health disparities, and I teach those courses. And I do that on purpose to show the importance of understanding health disparities. We have full Masters of Public Health scholarships for any one of our students that wants to go through and do that. Now we're on our 15th year of student-run free clinics, and they're phenomenal. And then the foundations in town, that anybody that wants to do this underserved work will pay scholarships for them to be able to go through medical school as well. So it's been a real enjoyable ride, bringing the medical school alongside this whole journey of trying to improve our health disparities in the community. All right, I think I'm done. Great.
My name's Ross Bjorlund, and I'm one of the chief residents for the Department of Medicine. And on behalf of the department, just wanted to thank Dr. Clancy for a really great talk, and thank the Brody Lecture Series for bringing him in. Dr. Clancy's talk, I think, highlights a lot of important facts. One of those is that we've got some serious and pretty embarrassing healthcare disparities across our nation, and Charlottesville is certainly a community that is not immune to those as well. And I think your other points of that this, in order to fix these issues, is going to take a multidisciplinary approach in order to make any true lasting impact. And one of the biggest parts of that multidisciplinary approach is involving the community early and having a true community partnership. And so I think that's something key and something that we can all really learn from. At this time, if anybody has any questions, please just let us know.
Please identify yourself when you ask your question with your name and where you're from.
Pam DeGuzman, I'm at the School of Nursing, and this is actually a little bit more of a statement than a question, but I want to say I really appreciate your use of what I call micro-targeting in neighborhoods. I do that similar research looking at using GIS to identify disparities. I've just written a paper about late-stage breast cancer in poor neighborhoods in Virginia cities. And what I found surprising, and what I think is so valuable about the micro-targeting is that in Richmond in particular, some of the worst neighborhoods with late-stage breast cancer are those that sit right on top of VCU. So it's not an access issue, and so it's so important that we be able to go in and identify for each community what is the issue, and now we're in the process of trying to get into those neighborhoods and figure out, well, what is going on if it's not an access issue. But similar to that, I want to say it's so important that we have the data to be able to do this analysis, and there has been some efforts at the federal level to limit some access to federal data, but as researchers, we need to make sure that these data sets stay available at the neighborhood level. And there's a lot of issues with that, with HIPAA and privacy, but if we're going to be able to target these neighborhoods, that's something I think we all need to fight for. Thank you.
I agree.
Thank you for your lecture. I have a question. Do you have data on the ratio of women who need psychiatric help in Oklahoma? And if yes, what are the reasons why they have this problem with mental health?
Yeah. So we don't have the differences between men and women yet. We don't have the differences between races as well. We don't have that yet, but we're drilling down and getting all the fine details to it. It's a great question as to why do we have the highest percentage of mental illness in America, and I don't have the definitive answer yet. I do have some ideas. The first is poverty is certainly a factor. The second is trauma is a factor. We're a high child abuse, high domestic violence state as well, and those are linked clearly to depressive disorders, so we know that. We're also a state that is not very pro-seeking mental health treatment as well. And so there's a lot of, the stigma level in rural Oklahoma is very high as far as seeking mental health. When I started my clinic in North Tulsa, every patient I saw, none of them had ever seen a psychiatrist. And many of them, they've been laboring with their illness for more than 20 years. So there's just the stigma of not even going to treatment in the first place. Your strongest predictor of suicide is depth of clinical depression and seriousness of it. So if you don't treat clinical depression well, then you're going to be a high suicide state as well.
Hi, Jerry. Thank you very much. We did have a chance to talk the other night, and I think I said it to you there, but I want to say it publicly. You become my latest hero. I think the work you've done from a leadership perspective in your community, harnessing the energies of a distinguished medical school and focusing them on those community needs is really an example that I think we as leaders all need to develop. I just make a couple of observations. One is I think your point about this problem not being amenable to traditional solutions is really important. We're going to need a clean piece of paper with new structures and new systems and new work processes in order to get our hands around, particularly the mental health and substance abuse issues as they pertain to this overall global health piece. So I think that's really important, and it's not likely the existing systems will afford us that opportunity. I think the second thing around our aspirational goal of being a healthy place to live and work bears insights from our Be Well initiative. So we started a program to understand the health and wellness issues that confront our employees, people that I would argue, as a leader, I go to bed at night thinking they get a decent paycheck, they've got health benefits, must be a great world out there. Not so much. Yeah. The fourth most common chronic condition a UVA employee suffers from is depression. And it accounts for 8 times the amount of annual medical spend if you have depression and hypertension, depression and diabetes, than it does if you have that other chronic condition alone. Yeah. And so it's not just a matter of looking to our community as some foreign place. It is our workforce in the community that when they leave work often suffer from these conditions and bring them to work. Yeah. So we're trying to learn some lessons internally about what the forces are that are driving that as a way to inform what we want to do externally. So I can't thank you enough. I'd like you to come back every year. I think the Brody Scholars ought to have an alumni association, and I would ask you to be the chair of that. But thank you for inspiring us, and thank you for informing us about the way to move forward.
Thank you, Ray. Thank you for those very nice comments. We had a similar experience with our own employees at the University of Tulsa. We had a chemical spill that required us to have a rapid response medical team on a group of employees that were exposed or possibly exposed. And in doing that very in-depth evaluation of those employees, we found out that a huge number of them did not have, even though they had insurance from the university, did not have a primary care provider. And most had not seen a physician in 10 to 15 years. And we picked up all sorts of underlying diseases that they had no idea that they had, including diabetes and hypertension and anemias of great concern. So, and I've learned that same lesson as we're doing the mental health study, in that as we opened up the to the community that we're doing this study, people are coming to me telling me their stories. And these are families of great resources, and they still can't get what they need as far as care. On your earlier comment about a blank sheet of paper, we're actually going to use some of these cases, including the mental health, for my freshman leadership class on design thinking. And here is an impossible set of problems. Now let's actually, rather than walking away from it, let's design a solution that's going to work. So we're going to use this with 18-year-olds, and we'll see how it goes.
Other comments and questions? Yes. Give the mic to you.
Hello, my name's Sally, and I work in health promotion over in student health. And I'm wondering if you can comment on any ideas that you have for rural America. I understand that you're working in an urban setting, but often the ways that you can solve problems in urban settings are not directly applicable to parts of the country that are just a lot more sparsely populated, and it isn't feasible to locate in clinics so close to where people are living.
Yeah. So we are a rural state like Virginia, with urban and rural centers as well. And our rural is very rural. We have entire counties with no physicians at all. So, and we struggle with this. And of course, we use telemedicine extension as much as we can. But really, I think that you have to look at what is even in those rural settings, what is the community anchor? And that community anchor is either going to be the school or it's going to be the church. And you have to go there. You have to go there, because there's got to be a place where you can collect with others. You can't go and do a house visit to everybody in rural America. So you've got to see what is the anchor. One of the parts of the story that I left out with North Tulsa was we really got rolling with the heart intervention program when the churches got on board. And we had the pastors in North Tulsa saying, you need to go and get evaluated by these guys. And that's how we suddenly got 300 people into the program. It was through the churches. So, yeah.
Thank you.
We can continue with questions. Just please raise your voice a little bit, because our sound system's been knocked out by the storm.
I should look that up on my app.
What did you bring with you?
I'll tell you all about it.
Yeah. Tell us your focus. Go ahead.
John Ashley, preventive medicine physician. Could you discuss for us how you're, in your medical school and health science campus, integrating this mental health program with primary care, and both for physicians, nurses, and all those other disciplines that can play such an important role in mental health?
So I worry about that, because there's so much on the shoulders of primary care already. And every time I do a primary care talk, there is almost every physician stays behind and has a specific set of consultation questions they have for tricky patients, difficult patients that they're taking care of. So to think of primary care as going to be able to handle even more of this is, I think, a little bit putting a lot of pressure on primary care to do that. But that being said, in the middle of all this, so there's another chapter where we went after every single Affordable Care Act innovation grant you could get. And we got $16 million worth of innovation grants as we did this. including the patient-centered medical home team, where you had a behavioral health specialist embedded in primary care. And we are now one of 10 or so cities that is a demonstration project for this. And it's gone exceedingly well. The overall satisfaction of the docs and the patients is much, much higher having the behavioral health specialist in the primary care office. And we've had an 8% savings from year to year by having behavioral health actually in the primary care office. So I'm a big, big believer in the integration of behavioral health. The problem will be beyond a behavioral health specialist that is either a counselor or a social worker or a psychologist. What do you do when you need the advanced training of the psychiatrist, and we're not going to have that? I'm thinking of a pilot where the psychiatrist actually sits in almost an air traffic controller's office with a headset on, and all day long just helps primary care physicians go forward with the next steps with their patients. It's probably one of the only solutions to get enough psychiatrist expertise out there.
One last question?
Hello. So my question is actually thinking about accessing, sort of people early in childhood. So just, when I was a kid, I went to a school nurse. The school nurse did my eye exam, weight, all that stuff. I don't know if any of that still happens, but I just wonder if any of that stuff, the screening, would happen earlier so that you could kind of get people into, I know there are kids that are now doing mindfulness and yoga early in their lives in the school systems instead of detention, for example. So I'm just thinking about ways that you could end up doing that sort of screening, prevention, and then moving on from there. Is that something that people are thinking about?
Yeah, I do think they are, and even with the Israeli work around trauma is very much mindfulness and cognitive training and right there and right then. I mean, it's not just supportive care. They jump in with very focused interventions there. The federally qualified health centers have the opportunity to create a branch of their organization called school-based clinics. And there's federal dollars to do that. And where school-based clinics have been successful, you see improvements in test scores, you see improvements in family mobility, and you see improvements in teacher absenteeism as well. We had 20 school-based clinics in North Tulsa, in the elementary schools, and then the state pulled our funding. And it was going very, very well. We saw a 25% increase improvement in test scores and family mobility, which had been at about 90% changeover from year to year, had dropped down to about 50%. So it was
Well, we'll have to have you back for an update at some point. This sounds wonderful. And if the air outside, the weather outside has changed, I think the weather in here has changed too. It's a very hopeful and challenging presentation you've given us. And I hope we'll take the lessons home. Please do not join us next week. Medical Center Hour is observing UVA's spring break. But we will be back on the 15th of March with a program called Arrows and Illness, A Caregiver's Tale with David Morris from Richmond. We look forward to seeing you then. And again, please thank Jerry Clancy.